Okay, chapter 40. So now we talked about we're done with the respiratory system. We talked about the upper respiratory system, and we talked about the lower respiratory system. Now we're going to talk about the upper GI system and the lower GI system. So, what is included in the upper GI system?
The esophagus and the mouth.
Mouth, esophagus, what's next?
Stomach.
Stomach. That's all you'll need to think about right now. Mouth, esophagus, stomach. Then from there, we go through what?
Small
intestine. Look at y'all, did remember some stuff from Auntie. Small intestine, and then what? Large intestine. So for this first chapter, we're talking upper. So we're talking about our stomach up. Lower section, we're going to be talking small intestine down. Okay? Cat is eating. Okay. So these are just some terms that y'all need to know. H. pylori is a stomach bacteria that causes peptic ulcers. So it is a bacteria that eats away at the lining of your stomach. That is called H. pylori. When your patients have H. pylori, they are going to be on something to protect their stomach, some of the drugs that we're about to talk about, but they will also be on an antibiotic because it is a bacteria. Okay? These chapters are pretty easy, y'all. I think y'all are going to like them. All right. So the number one thing when we're making our little umbrella, open to page 40. Not page 40, chapter 40. Page 453. Upper GI drugs. We have acid neutralizers. You're making a little chart. Acid reducers. And then we have GI stimulants. And we have antiemetics. Those are our 4 subclasses. So acid neutralizers and acid reducers, they're going to be in a little box by themselves. They are going to be used for things. If we're reducing acid, what are we going to be using those things for?
Heartburn.
Heartburn, yes. Increased acid or heartburn. Indigestion, reflux are what those drugs are going to be used for. What would we use a stimulant for, a GI stimulant?
Constipation.
Not so much. Keep that in the, because we're not talking about lower GI. Like digestion.
Like malabsorption? No?
Yes. Okay, so if your patient, I didn't hear what you said, Haley.
To help digestion.
Yes, so if your patient has some kind of disorder, like they have diabetes and the nerves in their stomach are shot, and they have a disorder where your food should be processed out of your stomach within 4 hours for sure. But some people's just stays in their stomach and stays in their stomach and stays in their stomach. When we need it to break down and move on, right? We need it to go through that process. So a GI stimulant is going to stimulate that process, stimulate this, to get it going on more, to get the process rolling. So sometimes it is given for constipation because that constipation is related to the fact that their food is not moving down that system. Sometimes it's given for nausea because sometimes your patients are nauseated because that food is still, it's not going anywhere that it needs to go. So, but the whole goal of a stimulant is to get those gastric juices flowing and move that absorption along. And then antiemetics. What is emesis? Throw up. So if we're given an antiemetic, we're giving them for nausea and vomiting, right? So a lot of these drugs should sound really familiar to you guys. So what we want to talk about now, before we move on, the way I kind of gave y'all a little thing about the adrenergic and cholinergic, I want to talk about proton pump inhibitors, and I want to talk about H2. Okay, I want to read this to you. All right, we talked about histamine that's in the body, right? When we talked about antihistamines, and we said that some of those antihistamines, they're blocking H1. Some of those antihistamines, remember we said they might help with nausea, and they might help with other things that are going on. All right, so there's different receptors in the body, and those receptors are sensitive to different things. So the histamine receptor H2 belongs to a group of protein receptors. You don't have to write all this down. I'll simplify it in a second. It is an integral membrane protein, and it stimulates acid secretion. So remember those other histamines stimulated that response to the body with the watering of the eyes and the, all of that stuff? The H2 receptor stimulates that gastric secretion. It stimulates to release that acid. It regulates GI motility and is involved in cell growth and differentiation. So basically, the H2 receptor says we need to make more acid. We need to make more acid. We need to make more acid. So if we're giving an antagonist, we're saying you need to stop making that acid. You need to stop making that acid. Does that make sense? But if you don't know what that H2 thing does, then it doesn't make a lot of sense. The same is true. So a proton pump inhibitor, the proton pump is a part of your stomach that says, essentially, it's a different location. It's not caused by that histamine response, but it's also saying, secrete. We need you to secrete acid. We need you to secrete acid. So the way that these first two drug classes are working, they're either saying, the body is still saying, secrete the acid, and they're throwing in a blocker and saying, no, don't. Or they're inhibiting it from the source, from the protein pump. So that's there are two mechanisms of action. At the end of the day, the way we were writing that other little chart down, at the end of the day, H2 antagonists and proton pump inhibitors, I just told y'all their mechanism of action. What do we expect to see in our patient? What would we expect to see in our patient? What is our expected response?
Before they take it or after?
After they take it. So let's draw it. Okay. Can you see that by chance, Pat? The blank screen?
No, I don't.
Okay. It's all right. I'll draw this for everybody and upload it. Okay. If we have we're talking upper GI, right? Upper GI drug. Those first two subcategories, what were they?
Acid reducers and acid neutralizers.
Acid reducer, acid neutralizer. This is on page Pat. I'm just making a little tree branch, like a little umbrella. And I am on page 463.
Got it.
So this is going to be things like Tums. This is going to be things like your PPI, your protein pump inhibitors, like Nexium. Okay. Both of these, their mechanism of action is to reduce acid or to neutralize acid. What are we expecting for we're giving them to patients who have what? What is that problem that our patient has? What is their diagnosis? Heartburn. So GERD is their diagnosis. Some sort of reflux, gastrointestinal reflux disease, okay? So our patient has GERD. We're giving them an acid reducer and an acid neutralizer. Our expected response is, y'all said decrease acid, right? So what are we asking these patients in our assessment? What are we asking them?
After they take it?
After they take it.
There's stomach pain or throat burning?
Yes. Do you have stomach pain? Do you have throat burning? What about their meals?
Can you keep it down?
Can you keep it down? What kind of meals are you eating? What kind of meals are causing you to have this increase? Is it related to what you eat, Or is it all the time? Those are the types of information that we're going to be gathering for these people. Remember, we were asking for the upper airway and the lower airway. We're talking about phlegm and we're talking about snot. Here we're talking about meals and, indigestion and those sort of things. You want to take a picture of it? I can. Just so I can share it in case people want to know what it is. Now our other two subcategories are not going to be given for acid, problems with our acid. They're going to be given to stimulate. The only GI stimulant is Reglan. The only one. You need to know this drug forever. Its generic name is metoclopramide, metoclopramide. It stimulates it stimulates your gastrointestines to move along. It says, all right, whatever's in the stomach, we need to move it through the intestines. We need to move on, head out. It's given for diabetic gastroparesis. So it's not given for indigestion. It's given when your stomach contents are just staying there, when your gut is paralyzed. We sometimes give it for GERD because GERD is a secondary effect. If your food is not moving, then it's backing up, right? So sometimes it is given for GERD, but it is not the primary treatment for GERD. And it's also given for prevention of nausea and vomiting. But again, it's not that primary treatment, okay? The real true issue is that your gut is not moving that food along. What you need to always, always, always remember about Reglan. Have y'all ever heard of tardive dyskinesia? Do y'all know that word yet? Okay. Tardive dyskinesia. Look at the little box on page 462. Somebody read that out loud and I'll find y'all a video about what it looks like. Somebody read me that box.
It's a non-reversible involuntary muscle spasms, which is typically associated with conventional antipsychotics and known to occur with long-term use of metoclopramide. Immediately report extrapyramidal symptoms to prevent tardive dyskinesia from.
Okay, I'm not going to make y'all watch this whole video about Jeff, but when we learn about our psych meds, remember we've talked this whole time about risk versus benefits, right? If you're constantly puking because your guts don't move, then Reglan is a good option for you. But when it's taken on the long term, I'm going to show y'all what it causes. Our psych medications, when we learn about those, they cause this as well. It's a word you always need to remember. It's called tardive dyskinesia. There's a little video about Jeff right here. Jeff has severe tardive dyskinesia. I got to take my mask off for a second and show y'all. Have y'all ever gone somewhere, and I'm not making fun, and saw somebody that did this a lot?
We actually had a patient like that.
That is tardive dyskinesia. That's a mild form of it. Jeff, that I'm fixing to show y'all, he has a severe form. It's involuntary. They can't help it. Sometimes it's that. Sometimes it's twitching of the jaw. That is caused by medications that they've taken in the past, okay? And it's often irreversible. So at that first notice of it, it needs to be brought to somebody's attention before it worsens and worsens and worsens. At the end of the day, these decisions are made. You do this for the rest of your life, but you don't puke every day, or you don't do that. Those are risk versus benefits, but you need to be mindful that patients are going to be self-conscious of those side effects. And unfortunately, some people got these side effects or these adverse reactions before they knew that it was an adverse reaction. You know what I'm saying? Before they took these medications for years, before they connected it together. So I just want to show you this little video about Jeff so that y'all have a visual in your mind of what tardive dyskinesia looks like. and for people that can't see the video, I'm going to share all these links. So 500,000 people in the US have tardive dyskinesia.
My name is Jack. I live in Northeast Philadelphia. I was diagnosed with schizophrenia when I was 17 years old. I had a rough time growing up. There's a lot of difficult situations that I had to endure. Didn't have any friends at that time. Felt hopeless. But once I had my first breakdown, I was hospitalized then, right before I graduated high school. I stayed home basically that whole 1970. That was a whole decade that was unproductive, and if I continued to do that, I would wake up one day, an old man, and felt like I accomplished anything. I was seeing a psychiatrist, and he encouraged me to enroll into a mental health program. The program was very big on building social skills, making friends, and being part of society as a whole. And that was important because that made me build up my self-confidence. Over the years, I was on a lot of antipsychotic medication until I tried one particular psychiatric medication that as soon after I started taking it, I felt the best I did since I was a little boy. I had no self-consciousness, being out in public on this medication. When my psychiatrist warned me that I would develop physical symptoms in several years in the future, I wasn't really concerned about it because I was doing so well. I didn't want to have the risk of giving that up. Several years later, I woke up one morning and I noticed that my teeth were puffing in and out uncontrollably. And I was horrified when I saw my image in the mirror. And then the puffing in and out changed to grimacing. And I wasn't surprised that I was diagnosed with tardive dyskinesia, TD, because I knew grimacing.
Okay, so sometimes it's just small. You saw how he could talk for a little while and it was okay, and then sometimes it was significant. So that's something I want y'all to remember what that is when you have a patient with that. On first look, the thing about this, on first look, he would appear as someone who maybe wasn't all cognitively there. If you saw him walking down the street doing that, right? But he is cognitively intact. So just know that your patients who have these things, they're not necessarily, they can't control it. They can't. We had a nurse that we worked with, and I mean, hers was significant. Like it's almost distracting sometimes to speak to patients who have that. But I just need y'all to recognize it and know what it is. And Reglan causes that, okay? Reglan and a lot of the antipsychotic medications that we're going to talk about later on. I'll share the video, y'all. Okay, so let's get back to this. Okay, so I'm still going down the chart in the book, and then I'll go through the PowerPoint quickly. So, GI stimulant, the only one is Reglan. You have to know about Reglan. And then your antiemetic drugs. I want you to write next to promethazine. It's that fourth drug down. The generic name is Pharm. You're going to see that more than you see anything else.
Which one?
Promethazine, underneath antiemetics. You're going to go down 1, 2, 3. It's the fourth one.
And what's it called?
Pharm. PHENERGAN. That's going to be one of your most common drugs that you're given for nausea. And then for the HT3 receptor antagonist, your most common drug there is ondansetron or Zofran. Put a big star next to that one. Those are the two frontline medications for antiemetics.
It's amazing.
So those are, I'm still going to narrow down the drugs y'all need to know, but those are absolutely, you can't leave my class without knowing those three drugs, okay? All right, so back to, so those are the, if we were making our umbrella, those are all of our little subclasses. So now I'm just going to talk a little bit more about each subclass and hopefully knock this out pretty quick. All right, so antacids are against acid. The way that they work is they neutralize the acidity of the stomach by combining the hydrochloric acid and increasing the pH of the stomach. So antacids are going to basically, they don't stop that acid production like those proton pump inhibitors that I just told you. These are things like Tums. You take them and they neutralize. It's got a high pH and the stomach's got a low pH and we're just neutralizing. We're not affecting the release of or the protein pop. People will say, oh, it's coating my stomach. It's not really coating their stomach, it's just neutralizing it so that they don't feel the effects of that acid indigestion, okay? So then we have, overall the drugs, the other set of drugs can reduce the production and release of hydrochloric acid, and this includes the H2 receptor antagonists, proton pump inhibitors, and miscellaneous acid reducing agents. So those were those first two that I read to you guys about they either stop the stimulation, they stop that receptor from being stimulated, or they, at the pump site, they say, wait, stop, you can't release anymore. That's its two mechanism of actions. Proton pump inhibitors are particularly important in the treatment of H. pylori that I told y'all about at the beginning. H. pylori is what? It's a bacteria that does what? Causes peptic ulcers. So we're going to give an antibiotic plus a what? Yes, antibiotic plus a proton pump inhibitor. GI stimulants facilitate the emptying of the stomach. We talked about that. And antiemetics are used to treat and prevent nausea and vomiting. So acid neutralizers, I have already told you guys this. They're used in the treatment of heartburn, indigestion, sour stomach, GERD, and peptic ulcer. So if y'all want to write some of the examples of that on this slide, that would probably be helpful. Maalox, milk with magnesia. All right. So these things can cause constipation. Mainly it's going to be related to the stomach. Depending on what they have. If they have aluminum in them, then they're going to clog them up. If they have magnesium in it, then they're going to cause diarrhea. But we're messing with that pH, right? So we're messing with that pH. So depending on how we do that, that's what our symptoms are going to be. Our adverse reactions are going to be. All right. Some of these, so you saw that they had aluminum, magnesium, some of them have sodium. If they have sodium, we're not going to use them in patients who have cardiovascular problems. Because remember we talked about the water following the sodium, it could increase their pressure. So we're not going to give this to those patients. And so we're not going to give like calcium carbonate or calcium, anything with calcium to somebody who already has hypercalcemia, right? And hypercalcemia is a calcium of greater than what? 11. Yes, good job. All right. So we're going to use the magnesium and aluminum containing antacids very carefully in patients with kidney problems. And we're also going to use the calcium containing antacids cautiously in patients with renal impairment and kidney problems. So the issue with acid neutralizers is we don't usually want to give them within an hour, either an hour before or 2 hours after other medications. Why do y'all think? Yes, but how will it interact? Do you think the meds interact, or do you think something happens in the stomach? Yes. So we want our stomach to be acidic, right? We need it to be acidic in order to break stuff down, right? In order to get everything absorbed the way it needs to be absorbed. So if we're taking a Tums, always directly with another medication, or we're taking some of those acid neutralizers, it may interfere with the absorption of those other medications, okay? All right, H2 antagonists, these are the ones that are blocking that response to secrete acid. They inhibit the action of the histamine at the H2 receptor cells of the stomach, and they're used for the treatment of the same thing. All of these medications are treating that the decreased pH, increased acid, that acidic content of the stomach. Adverse reactions are dizziness, confusion, diarrhea. All right. H2 antagonists, we're not going to give these to people who have renal or hepatic impairment, which is with most drugs. We don't usually give them to the elderly or extremely debilitated patients. It's unlikely, but they can cause hallucinations. So when patients are very, very old, we don't want to, give them anything that might cause any worsening of dementia, that type of thing. And we're going to use them very carefully during pregnancy. And you see here that they can decrease the absorption of some of these H2 antagonists. Digoxin, we know, is a big drug that interacts. Proton pump inhibitors, I already told you guys, they are going to be more at that site where the acid is being stimulated. It's stopping it there in its tracks. So it suppresses gastric acid secretion. Headache, nausea, diarrhea, and abdominal pain. If y'all just think about it in such a way, we are messing with that equilibrium of the body. So most of our adverse reactions are going to have to do with the GI system for the most part. All right. If you want to look at these proton pump inhibitors, they all have the same ending. They can be found on page. So your H2 antagonists, they all end in IDINE. And your proton pump inhibitors end in prozole. Don't just look at the ZOLE, look at the whole prozole part, okay? Because you're going to have some other meds that end in ZOLE later on. But the prozole is the proton pump inhibitors. And you're going to, almost all of your patients, I shouldn't say almost all, but you're going to see these drugs over and over and over and over. A lot of people have problems with indigestion and reflux. So while I'm talking about that, what are some things that contribute to reflux? Do y'all know?
Spicy foods.
Spicy. The food we eat is one. Did you say something?
I was gonna say like tomato-based sauces.
Yes, all those already acidic foods like that. What is something that we can control? Y'all might know this. That has a very big effect on reflux.
Well, how late you eat.
Yes, like your positioning in bed is one thing. If you're eating and you're going to lie down directly, that backflow is a lot more prevalent. Your patient's weight. That's why we have a big issue in our country with reflux. Whenever you have a large abdominal girth, it is pushing that sphincter that is supposed to be at the bottom of your stomach, and well, the top of your stomach, is stretched. It's stretched and that acid comes back up. So weight is a very big contributor to acid reflux and GERD. So more drug-drug interactions. All right. I'm not going to go over these miscellaneous acid reducers. I just want you to know those two major classes. The number one stimulant is what? The only stimulant? Yeah, Reglan, yes. So I'm not going to go over that. We're not going to give them to patients with Parkinson's disease. Oops. Those patients already have significant, pass it up. They already have significant tremors, and we know that this can exacerbate that because of the tardive dyskinesia. Those movements, if you don't have the official diagnosis of tardive dyskinesia, if your patient starts exhibiting those signs of facial movements and facial tremors, it's called extrapyramidal symptoms. It should be on page. It's not, but that is the symptoms, and then that collection of symptoms, the disease or the manifestation of all of those symptoms is tardive dyskinesia. So that's more like the disease that's called, I say disease, that's the diagnosis. That group, the symptoms are called extrapyramidal, EXTRAPYRAMIDAL. All right. Antiemetics, they prevent vomiting. Vomiting can be caused by drugs, radiation, metabolic disorders. The most common issue with antiemetics as a whole is drowsiness. If drowsiness is one of our most common symptoms, then what are we concerned about as nurses? Safety, say it loud. Safety. All right, that I need y'all to think, if something says, if I ever tell you that a side effect of a medication is drowsiness, your number one response needs to be keep my patient safe, because your answers to your test questions are almost always going to be related to safety of those medications. All right. If your patient has CNS depression, central nervous system depression, if they're already sedated, are we going to give them medications that are going to increase that sedation? No. So they're going to be contraindicated in those patients. Some of these medications you will notice as we move on to our psych meds. So I wish I had time to do like a full lesson. Your triggers, they're called chemoreceptors in your brain. Those are the things that tell your stomach that you're nauseated. So those chemoreceptors are next to a lot of other receptors in the brain for serotonin and dopamine and all this other stuff. So a lot of these drugs you're going to see again, and they're used as antipsychotic drugs. So your job as a nurse is not to see one of these and say, oh, my patient's on a psych med. No, it could be used for nausea. It can be being used for something different. So you're going to see these medications again. So I just wanted to point that out. Cholinergic blocking drugs. So we talked about the cholinergic blocking drugs a while ago, and we were using them for something else. But you remember one of the things that our cholinergic blocking drugs do. So the parasympathetic stimulate secretion, right? Remember, rest and digest, so stimulating secretion. So our cholinergic blocking drugs are going to stop that secretion. If we're stopping that secretion, you know, whenever you are about to vomit, you know, does y'all's mouth get real watery? Like right before it's about to happen, your mouth gets really watery. Think about we're blocking that stimulation. So so think about that. All right. A lot of drug-drug interactions, and most of them have a lot to do. These drugs down here, lithium and prochlorperazine. The lithium is a medication that's used for bipolar disorder, and prochlorperazine is medication that is used for nausea. When they're given together, it increases their risk for those extrapyramidal effects. So it's a psych med that causes that, plus a nausea medication that causes that. It makes sense that we would exacerbate that and make it worse. Okay. Antiemetics are used to empty the stomach rapidly when a patient has accidentally or intentionally ingested a poison. So not antiemetics. Antiemetics are saying we don't want you to vomit. If your patient overdoses and they come to the hospital and we give them something like charcoal, we want them to vomit. We want them to puke up the contents of their stomach, okay? So those are emetics, so don't get them mixed up.
So that's not in the bag, that's not drugs we have to know.
Probably not. I don't think it's in the chart.
Yeah, it's not in the chart.
But if you see those words, emetic versus antiemetic, antiemetic means we don't want them to vomit. Emetics, these are usually almost only given in an emergent type situation. They're not drugs that you're going to encounter. Most of the time, we're not giving your patient drugs to say, here, you should probably go vomit today. That's not usually something we're doing. Okay.
Do that for like people who have like alcohol toxicity or no?
I don't know about, I know they hang banana bags for patients with alcohol toxicity. I don't, I think it's more poison and, like, ingested stuff. I don't think, I'll have to look that up there, but I don't think they do. I think they just hang a banana bag. Okay, so for these nursing assessments, I'm not going through those. They're going to be on the chart, and we're going to do a little thing in a minute where we're going to do some questions and stuff. And y'all know how to educate your patients. You just have to think about how it works. So you said it's worse at night when they're lying down. What might you instruct your patient to do?
Sit up.
Sit up for 30 minutes after meals and not lie right back down. If you know that it neutralizes their stomach, we might tell them to use caution when taking it with their medication. If we know that it might cause extrapyramidal side effects, what might we tell our patient?
To report that?
Report them. What is that? If they say, well, what am I reporting?
Like involuntary movement?
Yes, involuntary movement. So you know, based on what I already told you, you know what you would do as a nurse. You would ask them about their symptoms. You would ask them about their relief. You would ask them if they're vomiting. You know, I know it's so fun, but does it look like bile, or does it look like your food's not, you know, you're not processing your food at all? Are you throwing up the full, you know, dinner that you had and you can still see it? Or has it been broken down? You know, because that tells us what's happening internally. So I'm not going to ask you these. If y'all tell me, y'all want me to fly through the next chapter so you at least hear me talk about it, and then use that last like 10 minutes for a little like review, or do y'all want to watch that watch that recorded and review now? Vote of hands. I don't care. First option. All right. So I will record the chapter. Is it chapter 42?
41.
41. I don't know. I can't keep them straight. I will record chapter 41. I just want to throw these couple of things that I for sure need y'all to look at and throw them out to you now. I will do a quick thing. So, lower GI drugs. Before I tell you anything else, for the people who aren't here with me, we're not talking about upper GI drugs anymore. We're talking about lower GI drugs. Lower GI drugs would affect what two locations internally?
Small
Small intestine, Large intestine. If it's affecting our large intestine, what is it primarily affecting? Think about body processes. Pooping. These are the medications that are affecting our poop. Okay? So if they're affecting our poop, we are giving them for one of two things. What are those two things we're giving them for? Diarrhea, constipation. If you have not figured it out yet, your elderly patients are going to be overly obsessed with their bowels. They are, and I'm going to tell you why. It's because it does affect them. So this is like oversharing, but I'm going to do it anyway. When I had my children, worse than any of it was the fact that I couldn't use the bathroom for 10 days after I had my kids. Like, that was, for me, like, give me the rest of it, that sucked. So these people who are in the hospital, and they're taking these opioids, and they're taking all of this stuff, on top of everything else, they really just want to go to the bathroom because their stomach hurts. It's like that one extra thing that they have lost control over. So it's not always just about their bowels. You know what I'm saying? Like it's annoying that they can't poop and it's uncomfortable that they can't poop, but it's just one more thing to add to the fact that they're stuck in the hospital and they're in pain and they just had surgery and now they can't poop. Like it's like the icing on the cake. So all of these medications are either going to be talking about constipation or they're going to be talking about diarrhea. So when you look at the breakdown, this is a really sharp chapter. Actually, I can probably finish it in 5 minutes. I'm just going to keep talking. I know I gave you all a vote, but it'll be really fast. So they're either the first section. I don't need you to know this whole first section, but I just need you to hear what I'm saying. The medications that are used to treat inflammatory bowel disease. Inflammatory bowel disease is something like Crohn's. These are actually diseases. Something like Crohn's or, what's the other one? Drawing a blank. Say it again, Michelle.
Irritable bowel syndrome?
No, that's not the one I'm thinking of. I'll think of it in a second.
IBS?
No, that's not the one I'm thinking of. I can't think of it. But anyway, there's actual diseases where your body, your bowel gets inflamed and you cannot.
Celiac.
Celiac disease, yes. Thank you. So these medications are often, ulcerative colitis is the other one. Crohn's, ulcerative colitis, and celiac disease. These medications are often given IV to suppress that immune response, okay? They're not going directly for the absorption or affecting that small intestine. They're attacking the inflammatory response. So if something is attacking the inflammatory response, then your patient has an increased risk for infection because we're suppressing that inflammatory response, okay? So, but you don't need to know those drugs. The others, you have antidiarrheals. You need to know what they are. Laxatives. There's antiflatulence, which is, for gas. And then laxatives is that third section. What I needed to point out to you guys, I want y'all to look on page 471. There's a box at the top, and it talks about the different types of laxatives. That is something that will be very good for you to know throughout your career, and I'm going to tell you why. A stool softener is not the same as a stimulant laxative. A stimulant laxative is going to stimulate you to poop. A stool softener is just going to soften your stool and make it easier to poop. So you need to know the difference in those things, because when your patient is hospitalized and they just had surgery and they are taking narcotics and they're taking things that are going to cause constipation, when you tell them, oh, I have you a stool softener, they're going to say, oh, no, I'm going just fine. I'm going just fine. I went this morning. It's okay. But as nurses, we know you're not going to be going fine in 3 days. So if we soften up the stool, it's not necessarily going to make them poop like juice. It's just going to make it easier for them to poop. So I want y'all to know, like, what the difference is in those actions. That way, if your patient says, oh, no, 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 I can't have that, you'll be able to educate them better. Read your nursing alerts, and I will, that's really it for that whole chapter.
Can you go over what you said again about which ones we need to know?
Yes, I want you to look on, I want you to know box 41-1. I want you to know box 41-2. I want you to know that those are the drugs that can cause a lot of constipation. I do not want you to memorize the names of any of these drugs used to treat inflammatory bowel disease.
So we don't know that first section.
Yes, you don't need to know that first purple section. I'll give you your 40 drugs that you need to remember. I may pull one or two, like Humira is a drug that is used very frequently. I may pull one or two out of there, but I don't want y'all to spend all your time trying to memorize these medications because they're not medications unless you work in a hospital. Like, I'll probably have you know Linzess, because you're gonna get that orally in the hospital. And I'll probably have you know, like Humira, just to kind of know what it is. But you're not gonna see those things nearly as frequently as you're gonna see things like Lomodal and docusate sodium and, you know, all of those things. I want y'all to be familiar with the stuff that you're gonna have your hands on a daily basis. So that's one that I know that I don't want you to know. I am hoping, I know a lot of y'all are ready to study. I'm hoping that my goal is to have that list of those 40 medications by like 9 o'clock tonight. I'm hoping. Worst case scenario tomorrow morning. That way I would rather y'all, I've been thinking a lot about it. I would rather y'all know 40 solid medications and really know them and really be able to give them and really be like super strong, then I would rather you dabble in 100 and only come out knowing 7. Okay? And I feel like that's maybe where we were for some of these exams.
Yeah.
All right, so that is it. I'm gonna stop this recording and we're gonna play until 11. We're gonna play a little review game. Cool?
Okay.
All right. All right, Kat, you wanna just stay on and listen? Okay. And you can unmute yourself if you want.
Okay.